It remains a subject of some debate. So as I had mentioned, a very specific feature of the study when it was designed, that patients had to undergo a biopsy post-progression on trastuzumab-based therapy to confirm that the tumors were still HER2 positive before they received T-DXd. And indeed, we had several patients that we biopsied whose tumors were now T-DXd, who were now HER2 negative, making them ineligible for the study. So, it's been the standard practice at Memorial Sloan Kettering going back, 5-6 years, where we routinely biopsied every time a patient progresses on trastuzumab or on any HER2 therapy, because certainly you would not want to treat with a targeted therapy when the target is no longer present. Now, having said that, the Destiny Gastric 02 study was preceded by Destiny Gastric 01. So this was a study that was done in Japan and Korea. It was third-line therapy, and patients were randomized to T-DXd versus dealer's choice of chemotherapy. In that study, a pre-treatment biopsy after progression on trastuzumab was actually not required, and the activity in terms of response rate, progression-free survival, and overall survival actually strikingly similar between Destiny Gastric 01 and Destiny Gastric 02. So this does, to some degree, raise the question of whether you need to actually biopsy or not. And then certainly, I think we're all aware that in the US, the FDA recently approved T-DXd in a separate disease, in breast cancer, but for tumors that are HER2 low. So in other words, IHC 2+ and 1+ that are FISH negative, based on very, very significant activity. There is also a small data set from Destiny Gastric 01 looking at this HER2 low population. But it certainly looks like the response rate numerically is less in the HER2 low population than in the HER2 positive population. So I guess this is a pretty long-winded way of saying that while there's not exact clarity, I still think it makes sense to biopsy tumors at the time of progression on trastuzumab. Certainly, if one had a completely HER2 negative tumor, IHC 0+, I absolutely would not consider T-DXd. I personally also would not consider T-DXd unless the tumor were HER2 positive, but I think a biopsy is very helpful in that regard. A related question that we're frequently asked or we begin to consider: can there be a substitute for a biopsy, which is of course invasive, and sometimes it's not possible to biopsy a site that's progressing. So of course, circulating tumor DNA is being increasingly used. So the question is, can ERBB2 amplification found in the peripheral blood, can that be a substitute for a biopsy? Again, I would say that it probably depends, and I think it is an evolving area. But I think if a tumor biopsy absolutely cannot be performed, in certain circumstances, we are considering the use of ctDNA to guide whether additional HER2 therapy is indicated or not. Of course, there are no clear data for this, and it's an evolving field. But I think overall, I think biomarker analysis in any treatment, but specifically with regards to HER2 therapy, remains critical. I would argue that for now, the standard of care is a tumor biopsy after progression on trastuzumab to guide the choice of subsequent treatment.